Dan Petrylak from Yale University, and we're going to be talking about bladder cancer in the next session. This has been really a very exciting time in bladder cancer. There have been innovations and different strategies that have been developed that I think are changing the face of how we treat patients and really making an impact on their lives. So as we know, there are really two types of bladder cancer. There's the non-muscle invasive and the muscle invasive, and both of these types of or states of disease have had really significant advances in management. Nationally, there are about 81,000 new cases of urothelial carcinoma. This will result in about 15,000 deaths overall. And what I think really one of the major advances has been in metastatic disease. There's been a paradigm shift. So in the past, chemotherapy with platinum-based regimens such as GemCis or MVAC have shown an improvement in survival, but at 5 years, only 5 to 10% of patients were alive. The first advance came with maintenance immune therapy. For responding patients, you generally get about a 7 or 8 month improvement if you add a checkpoint inhibitor post-treatment. That's not for the non-responding patients. Those still have a very, very poor prognosis. But we've had improvements in survival with second-line agents such as pembrolizumab, and we need new agents. So one of the first approaches towards this has been a drug called enfortumab vedotin. This is an antibody-drug conjugate where 4 molecules of MMAE, which is methylmonorostatin, are conjugated with a monoclonal antibody that recognizes Nectin-4. And Nectin-4 is expressed in approximately 90% of urothelial carcinoma specimens. So this is really a targeted approach, and it's directed against the cancer cell. And the first approval in enfortumab vedotin came about 2 years ago with this publication in New England Journal of Medicine in second-line therapy showing about a 7-month improvement in median survival in favor of enfortumab compared to standard chemotherapy. And this is the intent to treat population. As we see, the hazard ratio is 0.7, and overall at 12 months, about half of patients are still alive with enfortumab vedotin. The median survival is 12 months. So, of course, with our more active agents, we'd like to move them up front. And in a phase 1 trial, it was shown that enfortumab combined with pembrolizumab had a response rate of about 70% and a median survival somewhere around 27 months. So this, of course, was moved up front into a randomized trial comparing enfortumab plus pembrolizumab to standard of care chemotherapy, either gemcitabine with cisplatin or carboplatin. And these are patients who had not received prior chemotherapy. As we see, there's really a dramatic improvement in overall survival. The hazard ratio is 0.47, and the median survival is approximately 32 months for those patients with enfortumab pembro, and it's about 17 months for the control arm. Now, there are some criticisms of this study. In those patients who were on the control arm, only about a third of patients received enfortumab in the salvage setting. Only about half of patients who are eligible to receive maintenance immune therapy received it. So there are some potential confounding factors that may have made these survival curves a little bit more disparate than they actually should have been. But nonetheless, this is now considered a standard of care. A couple of years ago, I would have jumped up and down excited about this particular data. This is comparing GemCis combined with nivolumab, a checkpoint inhibitor, comparing that to gemcitabine and cisplatin, and then nivolumab maintenance being given to those patients who were responding. So the reason that this was done was the fact that there did seem to be some distinction in patients treated with cisplatin versus carboplatin if you use checkpoint therapy up front. So this was limited to those patients who were cisplatin eligible. And lo and behold, a 22% reduction in the risk of death compared to chemotherapy. So that's great, but not good enough and not really comparable to enfortumab and pembro. And in fact, the only situations I could see you using this type of combination is if you are not eligible to receive enfortumab, and that may be because of peripheral neuropathy, but the platinum may contribute to that as well. So this is our current treatment paradigm for urothelial carcinoma. First line EV pembro or possibly GemCis or GemCarbo if they're not eligible for that. then on to maintenance therapy if those patients respond. And then what do you do in second line? Because we've moved now some of our more investigational treatments up front. Do we go forth with other agents such as sacituzumab govitecan, which is an ADC as well? Do we go with targeted therapy with erdafitinib for FGF patients? What do we do? Do we go back to Gemcis or Gemcarbo? We don't have any good answers to that particular question. But I do think that this is now going to shift our use of treatment earlier in urothelial carcinoma. As we know, cisplatin-based neoadjuvant chemotherapy does improve survival in those patients who are cisplatin eligible, a 14% reduction in the risk of death over time. And of course, now we're using maintenance therapy in those patients post-cystectomy. And there are two trials that have shown very, very similar data, showing an improvement in progression or disease-free survival in favor of the use of checkpoint therapy. This trial took patients with muscle-invasive bladder cancer post-cystectomy. If they had neoadjuvant chemotherapy, they were T2 or higher. If they did not have neoadjuvant chemotherapy, they were T3 or higher, and they were randomized to receive nivolumab or placebo, and they were treated for 1 year. So as we see here, there was an improvement in the intent to treat population for disease-free survival and a more pronounced improvement in those patients who were PD-L1 positive. Same thing with distant metastasis-free survival as well. A little bit tighter curve for that, but nonetheless, again, an improvement in favor of adjuvant nivolumab. The Ambassador trial, which was done in the cooperative groups, compared pembrolizumab to observation in a very, very similar group of patients. And again, we saw similar results with that. But the question, of course, is can we move these treatments up front in the neoadjuvant setting? This is some data that I presented 2 years ago at ASCO GU, the EV-103 Cohort H study, where we took patients who were cisplatin ineligible. These patients that could not have received neoadjuvant therapy otherwise, received 3 cycles of neoadjuvant enfortumab, and then they went on to radical cystectomy. And lo and behold, we had a pathological complete response rate of about 36%, which is comparable to platinum-based chemotherapy. Now, these are very, very small numbers, but again, this is hypothesis generating. And here we see the data from MVAC or high-dose MVAC in those patients who are cisplatin eligible. So there was a second cohort that actually gave the same schedule and dosage of EV monotherapy, then did surgery, and then actually gave maintenance therapy afterwards, or adjuvant therapy. We don't have the adjuvant therapy data on this trial yet, but again, a 34% pathological complete response rate and a 42% disease-free downstaging rate as well. So 42% complete response comparable downstaging comparable to what we saw in the other study. So where does that lead us now? Where there are trials that have looked at this combination of EV-Pembro in the neoadjuvant setting, I don't see any reason why we would expect the data to be different in this particular situation. In other words, compared to standard chemotherapy, the question is going to be in toxicity, and we'll talk about that in the clinical trial section later on, how we're trying to deal with that. But the major toxicities of EV-Pembro are skin rash and peripheral neuropathy. And unfortunately, once the neuropathy occurs, it can be a significant problem, and it generally doesn't go away. So if you're going to give this in the neoadjuvant setting, you really have to be careful and monitor your patients, because this can be a significant issue. But this trial has a neoadjuvant and an adjuvant phase, giving pembrolizumab as a single agent, or EV-Pembro, and then we're looking again at disease-free and overall survival, and they're stratified based upon cisplatin eligibility. There's another trial that is still accruing patients. It's the VOLGA study, and that's giving a different checkpoint, durvalumab, either with tremelimumab, which is a CTLA-4 inhibitor, and that's arm 1 and arm 2. These are combined with enfortumab vedotin. And these are platinum-ineligible patients, so these patients are going straight on to cystectomy if they don't randomize to the 2 treatment arms. So, as I said, this is a very, very exciting time in urothelial carcinoma. Survival has doubled in patients with metastatic disease when they've been treated with enfortumab and pembrolizumab. Trials are now moving these agents up front, and they're maturing, so we should see some data very, very soon on these. The effect on downstream treatment, I think, is really, really important. What are we going to do in the future? How are we going to sequence agents? Can you give checkpoints to a patient who has metastatic disease who's received that in the neoadjuvant or adjuvant setting? Do you get the same response rate? My gut feeling will be no, because other solid tumors don't have that particular issue. But future trials should be focused on improving survival, preserving the bladder, and also reducing toxicity of these particular agents.